Dr. Jeffrey Cheung has agreed to present, and we are very pleased to have him here today. He completed his PhD in the Institute of Medical Science at the University of Toronto, and prior to that, acquired a bachelor's in neuroscience and a master's in medical science. Shortly after his defense, Jeffrey was recruited by the University of Illinois at Chicago in the Department of Medical Education, where he will be off to in January to start his own center, I imagine, and continue his work. His PhD research explored the impact of integrating the why with the how in the instructional design of simulation-based procedural skills. And as with most sim-based education research, the concern over simulation fidelity was a constant running tension through his work. So he decided to embrace the infidelity in his approach to education research. We'll hear a bit about that now.
Thank you for having me here. So conflict of interest, I am trained, I totally believe in fidelity. Thank my wife for allowing me to have this title. Today I'm going to present some work from my PhD, and it's on the topic of simulation and simulation instructional design. And I hope that through this talk, I can encourage us to think a bit differently about the way we conceptualize simulation, I hope we can improve the way that we utilize it to construct effective education. So in simulation, simulation is an educational tool that really lots and lots of resources have been invested towards the integration of simulation within healthcare curricula. So as a mandatory component of both teaching and assessment by national accreditation boards, rightfully so. However, despite these resources being devoted towards simulation, there's still quite a long way we have to go towards understanding how we can optimally use simulation. And I think through my analysis of this, I think a key challenge to simulation-based training is something that's quite major and quite obvious, and that's the fact that simulation is not reality. So that means that regardless of what a simulator is, training on a simulator isn't going to be the same thing as training on a real patient. And because of that, when using simulation, this necessitates that we prepare our trainees for the transfer of learning, meaning that trainees are able to take what they've learned from the simulated setting and apply that outside of the simulated setting to novel contexts and novel situations. So for example, performing a procedure learned in simulation on a real patient. So transfer, however, is difficult. And we know from the education and psychology literature that learners often struggle to see the connections between what they've learned in one context and to see its applications to a novel context. So to address this gap between learning with real patients and learning with simulation, what educators and researchers in health professions have really typically tried to do is to create this greater alignment between simulated experiences and real experiences. And what this has led to is simulators that have been designed to be more and more realistic. However, despite this greater realism, more realistic simulations haven't really shown to be any more effective in supporting transfer than less realistic simulations. And in this pursuit of greater realism, I think we may have lost sight of the ultimate goal of simulation. And really it's not about building simulations that are better capture reality. It's about building simulations that better support transfer. And I think if we begin to focus on this goal of transfer, we may begin to think about simulation design very differently. So rather than considering what we're building at the level of simulation, by thinking about transfer, we're encouraging ourselves to think about what we're building here at the level of cognition, where we can begin to examine the ingredients that are required for transfer and start to consider how we might put them together. So a line of education research outside of simulation suggests that transfer requires a combination of two different kinds of knowledge. The first one being procedural knowledge, which pertains to knowing how to appropriately perform the steps of a skill, and conceptual knowledge, which pertains to knowing why each step of that skill is performed in the prescribed manner and sequence. And when trainees have an integrated understanding of both this how and why knowledge, they've been shown to be better able to demonstrate successful transfer. And in health professions education, the benefits of integrating this how and why knowledge have been demonstrated in a series of experiments within the realm of clinical reasoning. So in addition to teaching trainees the instructions, the procedural instructions of how to diagnose a specific disease from its given signs and symptoms, it's also important, this work has demonstrated that it's also important to teach the basic science that explains the pathophysiology of a disease that causes these signs and symptoms. So this why knowledge. Here, this basic science serves as this conceptual foundation that helps learners organize this procedural how knowledge in robust and meaningful ways that supports transfer. In clinical experts, this integrated knowledge allows them to be adaptive and flexible with their clinical reasoning and enables them to be able to effectively transfer their skills across contexts. So according to this research, the transfer benefits from this sort of integration of how and why knowledge is most effective when it's facilitating what is known as cognitive integration. So that's integration that occurs at the level of cognition, where learners are building these conceptual connections between procedural and conceptual knowledges. Importantly, what this work has shown is that in order to support cognitive integration effectively, what integrated instruction needs to do is explain and create these causal linkages between this how and why knowledge. So really trying to highlight this cause and effect relationship that exists between what one is doing and the conceptual rationale for why you're doing that something. Now, this is in contrast to much of integration that has occurred at the level of curricula, where this why and how knowledge are compartmentalized across a curriculum, therefore making it more difficult for learners to see these cause and effect relationships between these two different types of knowledges, and thus limiting their ability to engage in cognitive integration. So building from this work in my PhD, I wanted to explore how this idea of cognitive integration might be applied within the realm of procedural skills that are taught in simulation. So in general, these are the general research aims I had for my PhD. And essentially what they tried to address was this relationship between including conceptual knowledge, this relationship between that and cognitive integration, and the ability for trainees to demonstrate transfer. So in my very first study of my PhD, I just tried to address these two first research aims here. And what I hypothesized really was that individuals, if we taught individuals conceptual knowledge, that greater conceptual knowledge would be related to improved transfer, and further, that this integrated instruction would facilitate both improvements in conceptual knowledge and transfer. So really what I was trying to figure out was, what happens to transfer when we consider conceptual knowledge in the mix of our simulation instructional design. So to test this, in a series of, my very first experiment, what I did was looking at the skill of lumbar puncture, I separated out the procedural and conceptual knowledge instructional components of how you teach somebody how to perform a lumbar puncture. So with these two different kinds of knowledge, for example, I'll give you an example of procedural knowledge. So when teaching trainees how to insert a spinal needle, procedural knowledge content might look something like this. So inserting your spinal needle, position the needle at the center of the intended puncture site, angled at a slight 15 degrees towards the patient's head. And conceptual knowledge content would look something like this, and it would come after procedural knowledge, and it would describe why the needle should be positioned at the center of the intended puncture site. So, yeah, I'll let you read that. And further, why that needle should be angled at that slight 15 degrees. So with these two different types of knowledge separated out, I went on to develop two different instructional videos that would teach differing components of this. So essentially I developed two instructional videos. One video contained only this procedural instruction, demonstrating how to effectively perform a lumbar puncture, and an integrated for causation video that was designed to highlight this cause and effect relationship between these procedural instructions and these conceptual knowledge components. So I went on to recruit some medical students, randomized into one of these two groups. They reviewed these instructional videos for the same amount of time. And then they all engaged in 1 hour of simulation-based training for lumbar puncture. And after 1 week, they all came back to our laboratories and completed a transfer test, as well as a written procedural knowledge and conceptual knowledge test. So in terms of what they were training on, they were training on a simulated scenario with a patient that had normal anatomy, where the procedure was performed with the patient laying on their side. And to test for transfer, we changed it up a bit. We gave them a scenario where the patient was now an obese patient and needed the procedure to be performed with them sitting upright. And with the simulator we were able to change the anatomical insert we had inside, such that it could reflect that of an obese patient, the anatomy, such that there was extra tissue, making it more difficult to palpate, and changing the, I guess, the needle angle approach that they would have to take. So what did we find in this first study? Well, when we look at just the procedural knowledge scores, we find no differences between the groups. But when we look at conceptual knowledge scores, we find that individuals that viewed this integrated for causation video had higher conceptual knowledge scores. And further, when we look at this relationship between conceptual knowledge and transfer performance, we find that trainees that had higher conceptual knowledge scores tended to perform better on transfer. So summarizing this all to help us understand the relationship between all three of these, what we find is that individuals that had this integrated for causation video, they tended to perform better on the conceptual knowledge score tests, conceptual knowledge test. And with regards to this relationship between conceptual knowledge and transfer, individuals that had more of it performed better at transfer. So using a statistical technique called mediation analysis, we're able to demonstrate that individuals that had this integrated instruction performed better on their transfer by virtue of these gains that they made in their conceptual knowledge. So what we seem to show then is that individuals that are trained with integrated instruction have better conceptual knowledge, and that conceptual knowledge then helps support their ability to adapt in this transfer test scenario. So addressing these two aims in our first study, what's sort of left behind is really this idea of, well, we've shown that conceptual knowledge seems to be important and related to transfer, but how should that conceptual knowledge be incorporated within our instructional design? Does it need to be designed in this cause and effect way that highlights these relationships between the how and the why, or can we just teach them it separately, for example? So what we did to address this question is really trying to figure out, so we recognize conceptual knowledge needs to be included, but do we really need cognitive integration and this cause and effect instruction to support that? So to clarify this, I compared two different approaches to integrating this conceptual knowledge with procedural knowledge. So again, using instructional videos. In addition to these two videos we had in the previous study, I created a third video, this time a video that was integrated in sequence. So instead of using these cause and effect relationships and explanations to explain the relationship between the how and why, this one was much more like what you'd expect from curriculum, where you really teach the theory first and you give opportunities for the practical knowledge second. So if we were to organize these instructional videos based upon how much we might anticipate them to support cognitive integration, we'd get something like this. And what we hypothesized was that as the instruction was more supportive of cognitive integration, we'd expect a stronger relationship between that instructional approach and improvements in transfer performance. So using the same study design as previously, we recruited some more medical students without experience in lumbar puncture, gave them that 1 hour of training within the simulated scenarios, and again, tested them on the same transfer tests and knowledge tests. So looking at procedural knowledge tests, no differences between the groups, as you might expect. And when we look at the conceptual knowledge test scores, what we start seeing is this dose-response relationship between, again, how much this instructional video was theorized to support cognitive integration and how much conceptual knowledge these learners gained by virtue of having that integrated instruction. And summarizing that again in this, mediation analysis, or this path analysis, we find that when comparing the two integrated groups to the procedural-only group, that again, we find that, as we saw in that previous graph, that individuals that had individuals that had the integrated instruction had higher conceptual knowledge scores, and also that regardless of group, individuals that had higher conceptual knowledge scores performed better on transfer. And using that mediation analysis, we find that same effect that shows that this integrated instruction seems to support transfer by supporting trainees' ability to gain conceptual knowledge. And when we compare the two integrated groups using that same analysis, we find that individuals that had that integrated for causation video, that this mediating effect was stronger in those individuals, indicating that this integrated for causation was more effective at supporting transfer than simply having these, having the how and the why integrated in sequence. So taken together, these findings show that the more explicit we make the more explicit we make these relationships between how and why knowledge, the better trainees are able to transfer. So therefore, it provides evidence that the benefits of cognitive integration that we see in clinical reasoning seems to also play a role in procedural skills training. So with this sort of established now, we found, hey, look, this work in clinical reasoning seems to apply within the realm of procedural skills and simulation. We went on to sort of try to address this question of, well, you know, we've sort of looked at how cognitive integration might be applied in an instructional video. How might it look like in simulation? So to this point, integrated instruction has usually been designed using text, images, and video-based instructional modalities. And without really any, I guess, we haven't seen any thought put into how this might change the way we think about simulator-based instructional modalities. So what we tried to do in the study was really reimagine simulator design through the lessons of the previous two studies. So rather than improving realism, thinking about what might a simulator that supports cognitive integration look like, and how might it therefore impact trainees' ability to transfer. So like the thinking being that perhaps it could support cognitive integration to an even higher level than we saw with our integrated for causation instruction. So once again, using the same two instructional videos as we saw in the previous two studies, we recruited a bunch of medical students to review one of the two videos. And again, we gave them 1 hour of training in a simulated-based training scenario, the same as before. But this time, individuals in the integrated for causation group, they received some additional integrated instructional modules during their actual simulation-based training. The thinking being that if we were to include this integrated instruction during simulation-based training, perhaps we might be able to, again, enhance cognitive integration. So individuals in this integrated group receive this additional integrated module, either in the form of a video-based integration module or a simulator-based integration module. So these integration modules, we developed 4 different modules that were part of the lumbar puncture procedure that were consistently considered challenging for learners or important from the perspective of experts. So we developed 4 of them in total. So 1 on sterility, 1 on cleaning the patient's back, 1 on how to set up your manometer system, and 1 on needle technique. So in each case, what would happen is that as a trainee was performing the scenario during their lumbar puncture training, they would have been directed to engage in one of these modules right before the pertinent step of that skill. So before, for example, in the case of sterility, for individuals, let's say in the video-based, receiving video-based modules, they would have been stopped before they were to put on their sterile gloves and would have been told, hey, before you put on your gloves, we just want you to review this instructional module, and they receive it in the form of a video. So in this instructional video, individuals in that video group would have seen this video that would have explained to them that, hey, before you put on your sterile gloves, we want to remind you that when you're putting them on, it's important to touch only the inside portion of that glove with your hands. And the reason being that your hands, they're not sterile, and you don't want to contaminate the gloves. So just be careful about that, because if you do that, you could increase the rates of infection for the patient, and we don't want that. So individuals in the simulator-based integration module group, they received the very same instructional content, but this time delivered through a simulator-based integration module. So they would have basically been stopped again and told to, hey, now we're going to complete this task. And what the task they received was essentially there was this sterile ping pong ball inside this bowl here. We want you to retrieve it in a sterile fashion without breaking sterility. And you're going to do it with the help of these sterile gloves. And then eventually what we also did was we covered this bowl with a little plate. So it would look something kind of like this. So you see the ping pong ball in there. And they were given some sterile gloves to engage with this. But there was a catch. So to simulate contamination, all non-sterile surfaces were covered in finger paint. And that includes the participants' hands. So the thinking being that by engaging with integration in this way, we could help learners more concretely experience the implications of this abstract concept of sterility in a very real, visceral, and integrated sort of fashion. So they could see the consequences of their physical actions and how that played a role in this idea of sterility, potentially enhancing their cognitive integration. So we developed the other modules in a similar fashion for both the video-based and simulator-based integration modules, all themed around this idea of making concepts visible and material for learners to experience. So in addition to these two groups of integrated instruction groups, we also had a control group, which was a group that had no modules. So essentially, they just engaged in that 1 hour of training with access to their instructional video. And like the previous studies, they engage in the same transfer test and the same 2 written knowledge tests. So what we find, as we saw in previous studies, no differences in procedural knowledge scores. But when we look at conceptual knowledge scores, we find that the individuals in the integrated groups perform better than the individuals that received procedural-only instruction. But we don't find much difference between the 2 integrated groups. Further, when we look at this relationship between conceptual knowledge and transfer, we find the same positive relationship between individuals that had more conceptual knowledge tended to perform better on transfer. Summarizing this again, using our same analysis as the previous studies, what we find again is that individuals in the integrated groups compared to procedural-only group performed better on the conceptual knowledge scores, knowledge test, and further that there was this positive relationship between conceptual knowledge and transfer performance. And using that mediation analysis, we show that, again, that individuals in this integrated groups, both of them, have significantly better transfer performance by virtue of these gains in conceptual knowledge. However, when we look at just the 2 integrated groups, we don't find a significant effect, which is unfortunate, but it wasn't what we were hypothesizing, unfortunately. So in addressing the final aim of this dissertation that I've completed now, the findings are a bit mixed. So it's not quite clear whether this simulator-based integration was superior to this video-based integration. And we think that there might be a bunch of reasons for that. So in addition to potentially enhancing cognitive integration, we could have also restricted learning in a number of ways. And these are some future avenues of research that I'll have to explore. So things like time on task. So by allowing learners to engage in these modules, we also deprive them of time to engage in these procedural scenarios. So it's something to explore in future studies. But what this work seems to demonstrate still is that replicating our previous studies and the work in clinical reasoning, we seem to show that there's this importance in including and considering conceptual knowledge when we're designing our simulation instructional design. And further, the way that we integrate this conceptual knowledge with procedural knowledge seems to play a role in modulating how well trainees, A, gain conceptual knowledge, and B, how well they're able to transfer their knowledge. Yeah, and I guess, yeah. So I think with the final studies in particular, what I'm trying to sort of offer up now is a novel way of thinking about some of the instructional possibilities that are available when we think about simulation instructional design from this lens of learning mechanisms, from this lens of cognitive integration in my case. So what it highlights really is that although simulation can be an effective tool in allowing learners to practice the procedural knowledge required to perform clinical skills, it's probably worthwhile to also start considering how simulation can be developed to help trainees develop their conceptual knowledge. And if we can help them develop both procedural and conceptual knowledge and help them to do it in ways that support this, you might be better able to prepare trainees for this. So what this work represents really is this beginning of a research program that's aimed at understanding the building blocks of effective simulation-based instruction. So rather than creating simulations that better align with reality, this line of inquiry suggests that simulation instructional design might be better served by aligning simulation instruction with the goal of transfer. And this can be done by considering the learning mechanisms that support transfer. And from there, designing our simulation-based instruction to support transfer by supporting these learning mechanisms. So in contrast to greater calls for greater realism, what my work seems to suggest is, what it argues really, is that simulation design should be about supporting the mechanisms that enhance transfer. And that's really because from the perspective of cognition and transfer, it probably doesn't matter if your simulator is made out of Lego. As long as it helps trainees integrate their understanding of how with their understanding of why, it's likely going to be a worthwhile educational experience. And really, by definition, simulation will never be able to capture all aspects of reality. But rather than a shortcoming of simulation, a lack of realism might actually be its greatest strength. It means that we don't have to follow the rules of reality, and that we can focus on what educationally matters. So I think my PhD gives a glimpse into what's possible through simulation in healthcare, and I believe that we can use simulation to make these abstract theoretical concepts visible and material for trainees, and in doing so, better prepare them for transfer, bringing us one step towards optimizing simulation to enhance healthcare education and healthcare. And with that, I will thank my committee members and collaborators and funding sources that have been with me on this journey, supporting me for many, many years. Yeah, pardon? Yeah. Yeah. So I guess with that, I can open the floor to any questions.
You've taken a particular tact on transfer, which is the same manipulation, LP, in the same intervertebral space, I suspect. What about with the skills they learned here transfer better to, say, venipuncture in an arm?
Yeah. That's totally a valid question. It's something we've thought about, and that originally it was, as every perhaps PhD student has, an overly ambitious plan of research studies. That was supposed to be one of the studies I did, which was to see the transfer across skills. Yes. Because if we're going to buy this idea of cognitive integration and this idea that it supports this ability to transfer, and if this concept of neurotechnique is similar across venipuncture as it is in lumbar puncture, you should see something, theoretically, you'd assume. Unfortunately, we weren't able to explore that yet, but I do think it's an area of future work I'd like to explore. And you may cringe at the idea, but the idea of preparation for future learning is something that I think I'd like to at least test to see if the principles of preparing someone conceptually using one set of skills helps them build upon these concepts as they learn in a new situation. But with regards to transfer, you're right, I totally did not describe transfer in a rigorous sort of manner. And really, in the case of my PhD, I mean, I can articulate that it's probably some form of FAR transfer, where there's a change in this contextual surface features of this problem that require an understanding of this conceptual idea of anatomy, that requires this conceptual idea of how a needle works, and that's what I'm testing. But really, I think what I'm trying to do here is working with the clinicians. It was really, how do we do something that is kind of relevant to clinical practice and kind of fits the bill for addressing what I'm interested in, which is really the ability to adapt to something. In terms of what kind of transfer that is, I'm impartial at this point, but I think as this work evolves, I'd be very interested in trying to tease that apart. So for example, what are these concepts that apply? So in terms of our transfer tests, even though some of these modules were built around sterility and setting up the manometer and cleaning the patient's back, I can't, it'd be a pretty weak argument to say that I tested for those rigorously by simply shifting the patient's anatomy. And I totally accept those limitations to the study. And I think it's definitely something that I'd be curious about teasing apart in future work. Because how far does this concept apply? How far does this, greater conceptual knowledge really bolster transfer learning? And I don't know. Yeah, I guess that's the best I can muster. Hopefully it's up to your
Question. So I'm thinking of, so you've got the analogy of the Lego, and I think that's appropriate because it's a little bit like, preparation for future learning might be about providing trainees with building blocks that, they could have at their accessible to them for whatever they need to build, and they can pull together whatever they need at that time. They have to have that right training to do that. But my concern is that something like preparation for future learning becomes, I don't know, kind of comical in a sense, right? So then we're back in the days of lateral thinking puzzles where, you know, or learning Latin, for example, might have improved your ability to think rationally. And is there a danger then in promoting this idea that infidelity of sim could be a strength, right? Because the worst thing would be for educators to think, well, let's get them to do some puzzles around the spine or build something out of clay so that they understand the anatomy better without knowing if that's effective or not. And then also, you could lose the trainees because they don't really see the point and they're not paying attention. I don't know if you came across any readings around that or had discussions around.
Yeah, so I think I don't think we're at the risk of doing that yet. I don't think anyone has talked about simulation infidelity in this way. And I think I don't mean to replace this sort of value of fidelity that we sort of place in simulation. I sort of position this idea of infidelity as a rhetorical sort of way of saying, what happens if we think about simulation in terms of infidelity? But really, I don't care if it's fidelity or infidelity. What I'm trying to articulate, I think, is that what we need to focus on are the learning mechanisms. So I totally agree with you that we don't want to lose the plot by purposefully engaging in lots of infidelity or you know, being totally true to fidelity. I think it's trying to get at this nuance of saying, well, if transfer is what we're looking for, and there are hypothesized learning mechanisms out there that are supposed to support transfer, why not just think about how we support these learning mechanisms? And sometimes that might mean including fidelity, sometimes it might mean actively rebelling against it. And I think oftentimes we're stuck in this bubble of thinking about things in terms of fidelity. And all I'm trying to do is say, well, what happens if you think about it outside of that? And what it really says is that, hey, it might not matter that much. But I do agree with you, I don't want everyone to say that you need to go buy Lego now. No conflict of interest, they're not paying me. Yeah, point well taken. So I need to be careful about how I make that argument. Yeah, I hope that makes sense.
Got me to my next point, which is you didn't operationalize fidelity versus infidelity as extremes on a continuum, did you?
No, I'm trying to stay out of that.
It's more like afidelity.
Yeah, potentially, right? I think it's me being a bit cheeky, right? It's just sort of raising the point, right? Saying, well, it doesn't matter. It is, you know, I'm an agnostic to it. What I would advocate for, and what I think my future work hopefully will try to address, is really, you know, I'm agnostic about whatever simulation feature you're manipulating. Fidelity, low fidelity, high fidelity, whatever you're discussing, functional fidelity, physics, whatever. What I care about is, what do you think that's doing in terms of the learner's cognition? What is that? If it's motivation you think it's affecting, well then show me that, and then show me the relationship between motivation and transfer. Whatever that feature is, right? And in my work, the reason why I think, well, I like this because it's my work, but also what this, no conflict there either. So what I think is what it allows us to do when we think about integration, maybe there are other learning mechanisms that allow us to do this, but really is it allows us to leverage simulation-specific properties that you don't have through video, you don't have in the clinical wards when you have real patients. And I think people are already engaging in this, but they don't use that language. So, for example, repeated practice. You could never do that in a real learning situation. But that's a virtue of simulation that allows us to engage in that you know, we all would assume has some bearing on how well trainees are prepared to do that in real life. So another thing would be like, but feedback or any sort of errorful performances, allowing trainees to make errors within a simulated scenario, those are, again, virtues of simulation that you would not be afforded in the real world. And I don't know if we've thought about it in that way, but I do think people already see the utility in it. I think this is more of a stark way of showing that, hey, you know, if you are a fidelity in your mindset, in your viewpoint, there is this potential theory that we have from the clinical reasoning literature and educational literature that suggests you might see benefits by actually engaging in this infidelity. But it isn't an argument that everyone should be engaging in that. it's sort of saying, let's think about this and think about the learning mechanisms. I guess, yeah, that's how I would put it.
Thanks very much for this. I find it interesting because as somebody who uses a lot of simulation in their own teaching, what you're describing sounds very much to me like how we teach rather than the idea of the physical simulator. So maybe I'll ask you to extrapolate a little bit, because it seems like all your research is procedurally based. A lot of what we use simulation for is around team training, crisis resource management. And do you see your research, is the logical step to compare it versus the way we currently do debriefing now? So if we assume that all our learning happens in the debriefing phase of the simulation, is it that we need to be better at teaching people the conceptual knowledge in that debriefing period so that they get something out of it so that they can integrate later on or transfer later on?
Yeah, so totally this work is procedurally focused, and it really is about how we teach, because it's really this idea of instructional design. So how should an educator design their instruction? And really this idea of integration, it doesn't come from procedural skills. It actually comes from clinical reasoning work and some of the education work in mathematics, typically. So in terms of debriefing or feedback or any sort of instruction, these same principles, I would argue, should apply. In terms of how you might specifically operationalize that in your own context, I'm not exactly sure. But I think this is where it invites educators to be creative about the ways they approach teaching what they're trying to teach. And it focuses us not on how real it was, but what do we want to teach them? What is the underlying knowledge that's there? And how do we thoughtfully integrate these or incorporate them in a way that allows the learners themselves to more easily draw these connections between these two types of knowledge? So a debriefing could be one way of doing that, and you could consider, well, how do we appropriately think about the conceptual knowledge for whatever skill we were teaching in this crisis resource management scenario, for example. What are those knowledges and how do we integrate them? Totally. It could also be thinking about, well, how do we actually, if integration is the name of the game, how do we actually do that within the sim itself? How can we create moments that allow us to talk about this in the debrief, for example? Or there's this, I haven't operationalized this, I don't think this is, we'll have to think about this idea some more, but there's a Key and Peele skit with Barack Obama's anger translator. So there's this idea that, you throw any insult at Barack Obama and he has this ability to just sort of, smoothly say something, and everyone's like, oh, he's so chill about this. And then you have what's really happening right there is that he's actually really pissed off, and this is what he really means when he says these things. So thinking about that skill and communication skills specifically, I've always had this crazy idea that, maybe within, if you're teaching communication skills using simulation, maybe that's an opportunity for educators, and maybe they already do this, but to just pause the scenario and say, you see when so-and-so nodded and said, yeah, well, what they really meant was, nah, not today. I don't want to do that for you. And teaching trainees how to read that could be a learning objective. It could be that we're identifying certain kinds of conceptual knowledge that we weren't thinking about before. So anyways, that was just a bit of an aside, but it is one manifestation of this idea of integration. So I'm not trying to be prescriptive about how or what skills you apply it for. I think theoretically, it could work for debriefing, it could work for procedural skills, it has worked definitely for clinical reasoning skills. And I'd be excited to continue exploring where the bounds of this idea are. Yeah.
Oh, sorry. Although, in the way that, because when you think of debriefing, I was thinking, well, that's a study you didn't run, which is the integration after the training.
Yeah.
Right? So that would be the next step.
Yeah, no, totally.
Or your student.
Yeah, well, yeah. There's lots of studies to explore.
It really nicely actually with Walter Epic's work on cognitive talk, and he's in Chicago, so I will.
Yeah, because it definitely is. I was just talking to Sam earlier about how I'm getting more and more interested about how educators approach their teaching and the strategies they employ. So I'm specifically interested in what happens if I gave them, these weird simulators that defy reality. How does an educator then use that in their teaching, or do they not? And I think, again, there's just millions of different, there's tons and tons of experiments and studies to do to help us understand, again, the limits of this idea. Because, eventually it probably won't be that useful. We will see. But yeah, I mean, I was talking to, so Nikki Woods, a lot of this work is based upon some of her PhD work, essentially. And I was talking with Jeff earlier about this, where the effects aren't as robust as she saw in her clinical reasoning work. So it appears that there's some sort of loss, something's lost in translation, or it's not a perfect fit from these more purely cognitive skills when you're applying them to, I would argue, a messier world of procedural skills. And I would imagine that it might even be amplified as you apply them towards more social skills like communication, etc. But, those are empirical questions to be asked and answered, I think.
So just to consider where you're looking for transfer. You're looking for transfer in your experimental design from simulator to simulator. Mm-hmm. Although the simulator's changed, as you say, you're able to change some of the internals, and you're changing patient position. Mm-hmm. It's still a simulator, so I'm going to make a guess that you're also considering transfer from simulator to live patient interaction. Yeah. It may be, I'm going to assume that based on essentially scheduling, it's going to be more difficult to do, because how do you create those opportunities? It's not necessarily all the time you're able to operationalize and find a bunch of people who need lumbar punctures. Yeah. And the other, essentially the interest is to say, would you be able to consider simulator to simulator near transfer and then possibly simulator to live patient interaction for transfer? Yeah, so I think this is where it gets tricky. It depends on what you're interested in showing. Yeah. And I think my understanding of education and its impact on, I guess, real world sorts of patient outcomes, I think you start getting into slippery, it's a slippery slope to sort of say that in order for our education research to be valued, we need to demonstrate it in patients. But I can see that, if someone wants to do that, I think it would be very difficult, but we could probably try to do that. What I'm personally more interested in is trying to identify these mechanisms. And I think as we refine and understand these mechanisms and figure out ways of manipulating them in meaningful ways and having control over that, I'd be more than happy to figure out ways of designing really, really rigorous interventions, educational interventions, and then potentially seeing how they pan out. But even then, I don't know, I'm a bit reticent. I've spoken with Jeff too much, I think. Yeah, so I think the takeaway from what I'm trying to show is really, it's a more mechanistic understanding of how learning works. And yeah, it's difficult to extrapolate that to say, hey, I have these instructional videos and materials, why don't you go use them? I don't think that's what I'm trying to do. They were specifically designed to test these specific mechanisms. But I think the question to ask would be, what is it that we gain by testing it on real patients? And I don't know. There may not be much gain.
Yeah.
As another consideration, you speak about, with respect to simulation, the opportunity to have repeat practice. And I don't know, do you have any thoughts about the opportunity to have large amounts of practice on a simulator, and then that becomes almost over-proceduralized, so the person's very good on a simulator, and then you change the context. Do you think there's some danger in maybe learning too much on a simulator?
Yeah, I think there's a rich literature on negative transfer, I think, and it definitely is a challenge, I think, if someone's only learned it in one single context. But I would make the argument that you could apply that within clinical practice. If someone's used to practicing in one clinical context, and you put them in another one, even though it's a lumbar puncture, they might not know where the tools are. They might not know who to call for help. That could be just as dangerous. I don't know what the cost-benefit analysis might be about that, but it definitely is a risk, which is why probably an important aspect is variation. Yep. What kinds of variation we have for training, though, that's an important question. So for me, I'd be interested in how the variation encourages integration. How does that help build conceptual understanding of the broader abstract concept of lumbar puncture? If we can even identify what that might be. Yeah, anyways. Okay.
An egregious example of what you're talking about is the Harvey simulator. The original
Very
Japanese
expensive
studies showed tremendous gains when they tested them on Harvey. Of course, Harvey has one of each of 29 different heart cells. So what they learned is Harvey's electrical stimulus, Harvey's
Yeah.
really good, and then couldn't generalize to others.
There's a piece in this series of studies that's a little bit depressing, I guess, because of how. Thanks for making me sad. But no, because the level at which you simplified a task that you could measure, and then we're able to measure some impact, right? And I guess I'm in my mind thinking there's still this translation piece, right? To some clinician educators, maybe not. Like, I wonder how much understanding of the intense investment in time to break that down for their students is kind of required to see those outcomes, right? And even if they take the mechanistic approach, it could still get, like you said, there's the effect size that he and colleagues were able to find for written cases and clinical reasoning, and then there's kind of the size of the effect that you were able to find for something a little bit more messy, let's say, or complex, I don't know. And then, of course, there's the real world and the real like classroom setting and different faculty and different students and different skills. And
that is a depressing thought.
Sorry.
On that note, I totally see that
not
too.
that you have an answer to that,
No.
but I think trying to get more and more of that messaging across that it's not just about a little tweak for integrating concepts and procedures. It's not just a one-time intervention, maybe. That's
and I think it's, again, what are you interested in, and I guess what are your goals? And I think it might be a fool's errand to try to do that using, extrapolate, these 3 studies. Took me ages to do, to any sort of broad, strong recommendation about how people should be, changing their entire curriculums. I think, all I did at PhD is, just a little nudge in a certain direction, and I think what I'm hoping for is to, it doesn't have to be one research group or one individual that does this work. I think what I'm trying to hopefully do is start a conversation that interests other people, and that, hopefully they can see the value of it in their own work, and, we can build, a beautiful building of research that actually potentially says something, right? I guess that's the more optimistic look at it, perhaps, right? But yeah, honestly, like, doing these studies, like, it's time consuming, you're really limited by how much you can extrapolate. Yeah, that's what we do.
Well, that wasn't a criticism of your work.
Oh, yeah.
It's the challenge. It's
Yeah,
the
I agree.
medical education challenge.
Yeah, I think it is a medical education. Yeah. No, I didn't take it personally off that. I was teasing. Lisa?
Thank you for a great talk. I think that what you're thinking about going from the other side might be a good mirror to what you've done currently experimentally, but to understand what and how teachers adapt some of their practices around a trainee who is having a lot of trouble with a concept or a maneuver or something like that. Because I think that in the troubleshooting that you'd see some, let's say, an expert, if you looked at expert or award-winning teachers and people have experience in that area, you might then bring back some of the things that people seem to naturally almost have PDSA'd their way through troubleshooting. Not like people that have only taught like once or twice, but rather people who seem to be able to be the remediation specialists and work through something.
Yeah, so I think we see this with just K-12 teaching, where teachers that are really proficient seem to have multiple analogies or multiple ways of teaching something or explaining something. So it's not the content expert in chemistry that's important, it's the teaching chemistry content expert that's a better teacher. That is one of the questions that I'm quite interested in, which is, my argument for some time has been that a lot of this stuff that I've done with these physical simulator materials, I think good educators probably do that, by virtue of their teaching. So they, by, either power of their explanation or whatever it might be, they're able to reveal those deep connections that exist between this how and the why. And I'd be curious to figure out how they do that and figure out, are there ways of, even changing like one thing that I thought was neat is a lot of the patient education. So when I go to a doctor's office and there's something that they want to explain to me, they'll have a model. They'll bring it out and they'll be like, hey, this is what's happening. This does this, X, Y, Z, blah, blah, blah. This is why we're going to do blah, 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 blah. And it's like, oh, cool. So I wonder if, expert teachers have their sort of toolkit of, well, when I'm teaching lumbar puncture, I bring this. It could be that, maybe they want to show the variety of different needles that they use. Maybe they want to show different kinds of kits that might be used. They might want to show different kinds of anatomy that exist. They might have to go to instructional videos. They might have go-to analogies. And those are the sorts of aspects of integration that I think I'd be very curious about looking into within, I guess, with a more nuanced sort of look at. I think educators that are, educators are worth their weight in gold, and good ones. There's probably these lessons to be learned from observing how they integrate this how and why knowledge.
Thank you very much for what.
Thank you for having me.